Goals of Care in Quebec's Healthcare System, a case study in policy adaptation.
Welcome, everyone. In this video, we're going to explore a crucial aspect of healthcare, one that touches the lives of patients, families, and providers alike. The video is built on the doctoral thesis of Ariane Plaisance. In North America, without a clear indication in the medical record, every person is subject to all life-sustaining treatments, including cardiopulmonary resuscitation. Goals of care discussions are conversations between healthcare providers and patients, and sometimes their families regarding what is most important to the patient in their healthcare journey. These discussions should happen throughout the care trajectory and involve discussions about the person's illness, values, and preferences, and the use or non-use of life-sustaining interventions, and eventually the completion of a goal of care form. To be valid, a goal of care form must be approved by a physician or a specialized nurse's signature, since it is, in fact, a medical prescription. But in Quebec's healthcare system, gaps in policy and practice lead to unequal goals of care practices. This study was conducted at Laval University. A team of 5 directors, an physician, a nurse, a spiritual care professional, a social worker, a citizen, a specialist in research and quality improvement, 3 physicians, and a researcher. The team was commissioned to create provincial guidelines aiming to improve the coherence between patients' values and preferences and end-of-life care. The study had 3 phases. First, interviews with nurses, social workers, and relatives of patients who died while receiving care. Second, carrying out critical audit of medical records. Third, designing a better functional system. The interviews during the first phase revealed disorganized practices, goals of care discussions were inconsistent, and when the forms are filled in healthcare facilities where no physician or specialized nurse is appointed, nurses and social workers often struggle to have them approved. During the second phase, the team audited about 600 medical records of patients who had an expected life expectancy of less than a year. The results exposed critical gaps of missing forms, unclear wishes, and poor documentation. Only 16% of the medical records of patients with a short life expectancy contained a valid goal of care form. During the third phase, with the aim of systematizing interprofessional discussions and decisions on goals of care, the team adapted a policy template provided by a provincial authority to the needs of the organization. It also developed a clinical framework to guide professionals in targeting people who could benefit from a discussion on goals of care. The clinical framework includes 6 health conditions of different stages of life, from health to end of life to sudden and severe illness. The adapted policy and the clinical framework introduced critical changes, defining patients' and families' roles, empowering social workers and the interdisciplinary care team, and integrating population-level education and awareness. The research led to the publication of 3 scientific articles, the adaptation of a policy, and the development of a clinical framework. However, the policy and the clinical framework were not implemented by the Regional Health Agency. Quebec's shift to interprofessional goals of care discussions and decisions faced barriers, role confusion, inadequate training, and forms reduced to do not resuscitate choice instead of holistic planning. Without systemic change, these inconsistencies will persist, leaving patients and families vulnerable to end-of-life care that does not align with their values and preferences.